Okay, I am Dr. Khanduga Rasulujjaman. I welcome you all in live case sessions. Today's live case operator is Professor Fazila Nesa Malik from National Heart Foundation, Dhaka, Bangladesh. May I request Professor Fazila Nesa Malik to introduce her team and as well as the brief history of the patients.
So good afternoon, everyone. It is indeed a great honor for us at National Heart Foundation to be doing this live case. And let me introduce our team members. So I've got Dr. Abdul Qayyum. We will be doing the case together. We've got Morsheduddin. Everyone knows him, our chief tech. We've got Zaid, another very talented tech. Russell, he's also one of our technicians. Then we've got Lipi, our cath lab chief of nursing. And we've got Mukta, she'll be helping Lipi, and we have got Khairul, our anesthetist, who really takes care of our patient, and we've got Elahi, who's helping us here as well. So quite a big crowd. So let me, without further ado, go to our case. Just a brief history. You all are aware that we are a 480-bedded tertiary cardiac care hospital and a non-profit organization. So we've been doing PCI since 1999 when we had a single cath lab. And up till last year, we've done more than 60,000 PCIs. And we started doing left main PCI on a regular basis since 2007. And up to December last year, we've done 3,669 left main cases. So coming back to our patient, this is a 65-year-old gentleman who has suffered old MI anteroseptal. He's hypertensive, diabetic, an ejection fraction of 48%, and this is his ECG. And I just want to mention that initially he was referred to the surgeons, and considering his creatinine, which was at that time 1.7, it's improved since then. They thought that PCI would be a great option for him. So his right side is not that remarkable, but as you can appreciate in the left side, he's got significant left main disease, which extends up to both the LAD and the LCX. The disease extends into the mid LAD. Can we go to the next slide, please? Yes, please. Can we go? So now let us go live. So we decided to, as you can see, there was a significant amount of calcium which was visible angiographically in the LAD and the left main. You can see the calcium angiographically visible. So we were a bit concerned about the extent of the calcium. So this is what we did up till now. And as you can see, the disease starts from the ostia of the left main, and we would see pressure damping as soon as our catheter sat there. So we have kept our catheter disengaged. We then proceeded to wire our vessel, and we had a look with the IVUS. And we can go to our IVUS findings, please. So in the IVUS, we found that there was a significant amount of calcium, 270 degrees of calcium. It was in some places very superficial, some places a bit deep, and there was nodular calcium as well. And the disease extended up to the ostia of the bifurcation of both the vessels, and there was also disease in the left main. And we did do some measurements, and we found that in the left main, the area was around 4 millimeters square, 4.3, and in the distal landing zone of a vessel, which was healthy, it was like 3-millimeter vessel. So considering the amount of calcium, we wanted to make sure whether this warranted some form of atherectomy device. So what we did is we took a balloon, and as you can appreciate, our balloon, this was a 2.5 millimeter 15-millimeter balloon. We went up to very high pressure, but as you can see, there's wasting, and our balloon open up that nicely. And you can appreciate the calcium sitting on the top of the proximal LAD. So without further ado, as this was nodular calcium as well, there were quite a few nodules there, we decided that we would opt for a rota here. And we took a 1.75 millimeter burr, considering the size of the vessel. And so we've done rotablation. We gave 2 to 3 runs, each run extending for 20 seconds. And after that, we did an IVUS as well, and it showed that there was considerable thinning of the calcium, as well as there was some fracturing. At this point, we wired our LCX, and this is where you have us. So after wiring the LCX, we were waiting because we didn't do any pre-dilatation. Otherwise, we would have to proceed further. So what we've done up till now is, in this gentleman, we've done a rota from left main to LED 1.75 millimeter burr, and we've wired the LCX to OM1. And as you can see, the plates of calcium have thinned out somewhat. There are some cracks and fractures as well. So that's us up till now. And our catheter is, as you can see, disengaged, because as soon as we place our catheter, the pressure gets damped. So now we are planning to really prepare our lesion well, because that is one of the key elements of success in a calcified vessel. You really need to prepare a lesion well. And so this is what we will do, if you permit us. So we are planning to use a scoring balloon here, 3.5 by 10 millimeter scoring balloon. Any comments from the panel? Hello?
Madam,
You can't.
are you hearing us?
Yes, we can hear you. Did you hear us?
Dr. Fazila, this is Dr. Asha Mailmaran. Hi. And
Hi,
excellent,
how are you?
very good. Excellent demonstration of the IVUS. Now, what is your plan for the LC? Are you going to go with a provisional strategy, or you want to go for an upfront two-stent?
No, I think we'll go for a provisional technique, even though in the IVUS, there is a sheet of calcium on the ostia of the LCX. Maybe we can show that to you. So we've wired the LCX, we're trying to safeguard it, but up till now, we're still opting for provisional stenting, okay? So that's our plan. But before we do anything with the LCX, we would like to prepare a lesion in the LED first. And maybe someone could show the IVUS of the LCX. So there's a sheet of calcium near the ostia of the LCX. So it's diseased as well, but let's see how things evolve. So now, as you can see, we've kept our catheter disengaged because we can't engage it because the pressure drops, and we're trying to take our balloon. Okay, so this is a 3.5 by 10 scoring balloon.
Apa, what was the rotor size?
1.75. So this was a large roomy vessel, and we took a 1.75.
Straightforward 1.75 you have started, Abba.
Yes, yes, we have straightforward. We have taken 1.75 because we felt that the IVUS.
Probably I have not understood clearly whether you have pre-dilated initially and then done rota.
No, we did. So let me explain. The thing is that we wanted to see the extent of the calcium. Okay, we want to see whether this vessel really warrants atherectomy. And one of the key points by which you can decide upfront atherectomy is if it is a balloon uncrossable lesion, or if it is a balloon undilatable lesion. So here our balloon did go, but it was not dilating properly. So, and when we saw that it was not dilating properly, we immediately opted for the rota. But obviously, of course, seeing the angiographic extent of the calcium and also the IVUS, we could have opted for the upfront rota technique anyway.
That means whenever we do not have IFAS in hand, the simple nature of how the balloon reacts, whether there's any dot coding or not, that gives us clue whether the lesion is heavily calcified or not, isn't it?
Absolutely. That was the teaching point for this demonstration. that we wanted to show our junior colleagues who are starting their career that yes, IVUS will indeed help. And what we saw as a result correspondent to our findings in the IVUS, that indeed this calcium was significant and it was creating a 270 degrees of horseshoe-shaped calcium. And here one interesting fact was that we did have superficial as well as deep calcium, but there were significant calcific nodules as well. And as you're aware, with nodules, it works better if you take a rota. So we have prepared our lesion with a scoring balloon, and I think we're quite happy with the result. So now we are taking our drug-eluting stent, and we are taking, you can have a look at what Murshid is holding, a 3.5 by 48 millimeter synergy. And a synergy is really, I mean, the length is great. So we plan to start from the ostia of the left main and go into the LAD. And let's see how things evolve.
What is the guide catheter you have used? Is it an XB or?
Yes, it's a XB. For us, it is customary to use an XB for all types of lesion. That is our workhorse catheter, you could say. We always use XB for the left side. So now we are taking a 3.5 by 48 synergy from left main. Our plan
Madam,
is-
have any significant lesions in the L6 ostium as well?
Yes, there is significant lesion in the LCX ostium. We can show it.
Can you
if
show us a yellow caudal view, madam?
You please, you can see here also. Can you see here that there is a significant disease from the ostia of the?
L6.
Sorry, I have to take my cat there. So we'll show it to you, but let me just take my.
Dr. Fazila, Fauzi from Indonesia.
Oh, hi, hello. Hi,
Yeah.
thank you for visiting us.
Yeah, very great, challenging case. What I saw from the IFOS, the opposite of the circumflex is calcified.
Yes, yes, absolutely.
So I'm afraid that when you open up the stent, is going to compromise the circumflex.
Yes, that
Would be good to have a gel balloon to preserve the circumflex.
I mean, actually, I think I would not opt for a jailed balloon here. The vessel is calcific, and I'm not really sure how a jailed balloon would behave here. So I'm going to go for, I've got a wire in the LCX. So if there is any problems, we can always rewire, and that is the aim. So we are hoping for a provisional type of stenting here. But if things go not that way, we were always all right to change our strategy. Now, one thing I'm doing here, and this is also a learning point for all of us. So this is, we're taking a floating wire or a cuspal wire. Now, why are we taking a floating or cuspal wire? Because it will prevent our catheter from going too much, and it will also guide us about the position of our stent. So that is.
What is your plan? Should you cover the ostium of the left main or?
Absolutely, I have to cover the ostium of the left main because there is pressure damping when my catheter goes. So I was also showed that there is significant disease in the ostia of the left main. So we have to cover that.
Madam, your
Sure, madam.
catheter is a extra backup catheter.
Yes, please. Yes.
Our younger colleagues, can you tell whether for a lesion involving the ostium, shall we
Can we
take
have a look again?
routinely the Judkins left or extra we can use extra backup, that is definitely, and also you are using, but for our younger colleagues, those who will learn, for them, can I add that when ostium is involved, it is better to use a Judkins catheter?
Absolutely. So you see, it's how comfortable you are with what you use. So as I said, for us, it's our default catheter is always the
Extra backup.
XB or extra
Yes.
backup. So
we also
we are removing our floating
All
wire,
right.
and we're pulling back our stent balloon. And we are going up.
And for our younger colleagues, to inflate the ostial stand, usually we keep in LAO cranial view for the newer ones. But for an expert, you can do anything in any view.
But the extra wire in the root actually help provide the ostium pinpoint, where you can put the proximal end of the stem. That really helps. Otherwise, you know, do that, allocranial would be better.
This is Professor Supriya Raman. You're
Assalamu
doing
alaikum, madam.
very well, you're doing, and I just want to answer the Ms. Jamal, Professor Ms. Jamal's one question, what he asked about the guide. Is a guide depends on the patient, no doubt about it. The lesion and the patient both, if it sits okay, then most of the time is the Japanese. But even if you wear the extra backup, use it, then you have to take it out of the ostia when you are implanting the stent. And that also can be done if you know how to handle it, and it's not a problem in the expert hands. And then there's no doubt about it. So when the mainstream is not আমরা যেটা বাংলায় বলি ছেলের হাতের মোয়া নাই, এটা করতে গেলে if you have a experience, you feel confident, then you can do it like they are doing it now. So you can use either, but the best is to start with Jatkin. If it doesn't go or doesn't fit or doesn't give you the support, then you can take it.
For the beginner or newer ones, having a stand crossing the left circumflex, you should do a wire in the circle. For the younger ones, for the newer ones, those who will start or who are doing or we are doing the left main angioplasty. For the expert one, no problem, but for us or those who are started, for them, I think it is very essential or mandatory.
We have a wire in the LCX as well, actually. As you have seen, our
but
wire
I
is
know
from the
for
LCX
newer
into the
one,
OM.
or for beginner, madam, I
Yes.
have told for
Yes,
beginner.
yes. And in this case also, we have opted to keep a wire in the LCX because there is significant disease in the LCX ostia, which is extending up to the OM1. So as you can see, we have a wire in the LCX. So we are ever so gently taking our catheter near. Now, one thing about left main, and if you've covered the ostia, don't do any jerky movements, as gentle as possible, because when the ostia covers the struts and when we've freshly deployed the stent, the catheter can sort of destroy or hamper your. So we're trying to get our catheter as close as possible, and then
Even now, I don't consider anything as simple PCI and you will come out without anything. So always, even now I put a wire there just because if something happens. then
yes,
it's all
totally
safe and
agree.
later on. That's the one strategy. And now the passing the second wire, you're trying, right?
Yes.
Third one, madam.
Yeah,
To-
so we have a jailed wire in the, LCX. So now we are trying to take our third wire, and our jailed wire is guiding us where to put our, and we've taken our wire with a micro. So if the micro goes easily, you know that you're inside the stent. If the micro had resisted, there is a possibility that you are underneath the struts. So one thing that you must have noticed, those who are starting, that we did a post dilatation with a 4 millimeter balloon. So even though we have a jailed wire, we have opened the struts of our stent in the proximal part to the best of our ability. Okay, so
For crossing, you have
and
used
now we are crossing into the LCX.
through microcatheter, madam.
Yes, we have a fine cross microcatheter, and that has helped us guide us. And we want to just follow this because this is a small branch there. So, but we have gone in, the wire is a bit straight, so it's sort of taking has a mind of its own and is wants to go to, but that's not an issue. So we are in. I'll take the microcatheter out and just let me. So
The pot was done with what size? 4.
now, yes, we did a pot with a 4 mm balloon. Now we are taking out our jailed wire. So let's be sure which is our jailed wire and then only pull it, right? So is this our
Madam,
jailed
for
wire?
recrossing the
Yes,
wire,
yes, yes.
should you
This is our
prefer the
jailed
twin
wire.
pass micro or regular micro catheter?
Regular fine cross. I
No,
use a fine cross.
no twin pass.
No, I mean, if you want a twin pass, of course you can. And sometimes a crusade or a twin pass can really be of help, but a fine cross works just fine in most instances.
Here several things are for younger colleagues. You are seeing elegant work by Professor Fazila Malik, and she is showing us. You are seeing, but you should have to learn that what she has done. Port, and port is very much essential before recrossing to any side branch through the stand. It is a must or it is mandatory. She has done it. You have seen it, and you should recapitulate it during your work.
Mir Jamal sir, one important issue is the pressure of the pot for aorta oscillation. It's a very important issue. What should be the pressure for pot of the aorta oscillation?
Pressure is always high. Pressure is always, port means the stand size in relation with the vessel size. Balloon will be in relation with the vessel size, meaning that my vessel is 4.5, stand available in my lab is 4, then I will never be able to make it 4.5 without port. And then I shall have to take 4.5 balloon to adequately cover the wall or adequately adjusted with the wall. And regarding pressure,
Yes.
it should be always higher pressure.
High pressure, definitely.
Elegant techniques which you can do is the pot puff technique. You do a pot and then give a small puff. If the puff does not go through and visualize the distal vessel, your pot is adequate. And
Definitely.
this was one of the award papers for the European EuroPCR.
And Dr. Asha, to you, my question is that to recross the wire, Professor Fazila Malik has used microcatheter. Do you use double lumen catheter? Double lumen catheter,
Twin pass.
crucial.
So only microcatheter. If it crosses by itself, it is okay. If it does not, you go, then you use a microcatheter.
Yes.
Usually a fine cross.
And regarding the wire of recross, do you use only your conventional wires, workhorse wire, or a hydrophilic wire?
You begin with attempting with a
Recross.
or run through wire. If you do not get it across, then you use
Post-dilatation of
LED.
LED.
the FC. You can use it.
Post-dilatation of LED we have not done yet.
Now opening up of the strut.
Can we have some more GTN, please? So now our catheter is inside the left main and we do not observe any damping of pressure, which is good news. Now we have a few work to do. First, we'll do post-dilatation of the LED stent that we deployed. Is this GTN? This is GTN.
Here another important issue for the younger colleagues, to place or to deep intubate a guide within a stand practically is very difficult job. You may distort the stand. That is why it is wise for the beginner to introduce the guide over the balloon. Pulling back the balloon, over the balloon, you enter into the stand and then withdraw the balloon. Otherwise, you may distort the stand. Many a time we get LM patient. Very recently, we have seen a younger dog, 32 years, done angioplasty in a different center and came within 3 months, severe stenosis, and on the table patient collapsed. Though we have done second time, but it should not be done, do second time LM angioplasty. But due to the on table patient
Okay.
shock, undergo shock, and that is why we have done. In that case, we have seen the previous stent was distorted, and that was most likely due to by the guide catheter.
So proper sizing of our stent and proper post dilatation, positioning, these are all crucial steps. So first of all, proper lesion preparation. When we are doing a left main PCI, it's very important that we prepare our lesion properly, and whatever tools is needed, we need to prepare that. Like for our case, we did rotablation, we used scoring balloon, and then we proceeded to do it. The second step would be to position our stent properly, and then third is to post dilate. So this is what we are doing for our LAD stent. It's a fairly long stent, a 48 mm stent. So we've taken a NC balloon and 3.5 by 15, and we are going up to high pressure.
Madam, what was the balloon in side branch? What is
The balloon. Okay, so we opened the strut of the side branch, and we did that with a 2 by 20
It is NC balloon or madam semi-compliant?
NC. Always when you're doing a procedure, it's safer to use a NC balloon. If it's a very roomy vessel, then you can consider using a semi-compliant balloon. But usually we use a NC balloon. So we're doing post dilatation of our.
Plan to do a DCB for the side branch in this case?
That's a great suggestion, and maybe we can do that. And let's see how the things evolve. And that would be something good to do, because then we don't have too much metal mass in the carina. And as this is not that big a vessel, maybe we can get away with doing a DCB, even though the Medina is Medina 111. So.
One other thing, I know a lot of you are now doing the main stem and bifurcation lesion. Has any of you have done the IVL for these lesions?
Yeah.
Can you throw some light on it, please?
Yes, madam, we've done IVL on left main, and actually after that we did a double stent technique, a culotte technique there, because the disease was so severe. So we have done IVL. And here we didn't do IVL because there was nodular calcium as well. And in nodular calcium, actually rotor works better. But yes, that is also another tool that helps us to tackle calcium, because nowadays, as we go and treat more elderly patients, more patients with chronic kidney disease, with diabetes, we are seeing a lot of calcium in these patients. And nowadays people have very complex anatomy, and these patients warrant different strategies to tackle their calcium. And indeed, IVL is also such a tool that helps us. But one thing we need to remember, that I personally find the rotor to be very versatile, because like if it's a balloon uncrossable lesion, you can't take IVL initially. Maybe later on you can do that. But with a rotor, if you can pass the rotor wire, you can go ahead and create a passage through which you can subsequently take your other tools. So this is our result. Now we have to decide what we want to do with our LCX to OM lesion. Do we just do a DCB as was suggested, or do we go for a double stent technique, or what? We've already pre-dilated this lesion once we rewired it with a 2 by 15 millimeter balloon, 2 by 20 millimeter balloon. And we'll take a view, and then the panel can tell us what to do.
Are you planning for a post-PCI IVAS?
Of course, that goes without saying. We have to do that, because imaging can help you, guide you in the technique that you choose. It can help you with the tools that you want. And of course, lastly, it helps you to see whether the result is satisfactory or do you need further optimization. So the imaging can guide you all through the steps. And of course, post-procedure IVAS would be very helpful. Now here we have, with the two, we have not managed to open up that vessel that much. Do we go for a larger sized balloon pre-dilatation, I'm not sure because we might end up with dissections and you don't really want significant dissection there. So let us, what I feel is that this is a narrow caliber vessel. We can try with a DCB maybe. So we plan to take a 2 by 30 millimeter DCB, which will go from the ostia of the circumflex to the OM1, which is a narrow caliber vessel as well. So,
Madam,
and
diagonal seems to be a very good size vessel, and what should be the strategy for diagonal, madam?
diagonal is fine. I mean, there's no
Fine.
flow
But
restriction.
this looks
So
osteoproximal lesions in the diagonal. I
So
couldn't see
maybe
the
we can have a,
radiocranial view.
I mean, the thing is, we don't go
Yeah.
and treat all the vessels. We've treated the left main to LAD, and I think we're quite happy with that. The diagonal disease might be there, but it's not flow limiting, and it's good. I would not be doing anything for this diagonal.
Radiocranial view looks good, madam.
Yes. So, I mean, that is another thing our juniors need to understand. You don't need to stent everything. It's like a tree. You treat the big things and so now we are taking a DCB, a 2 by 30 millimeter DCB for the ostia from the ostia.
Have any
to
role
the
of
OM1.
KBI in these cases?
We'll be doing a KBI. Of course, I mean, we'll be doing a KBI and we'll do a final report and then we'll do an imaging.
Oh, okay.
Please. So this is our DCB. And so we're inflating our DCB. So I think the rated burst pressure is 14 for this DCB. So we've started the timer and our aim is that we keep it inflated up till at least 1 minute. Now, if you're doing DCB in a left main, like we do sometimes for left main ISR, we shorten the inflation time, do it 30 minutes interval, 30 seconds. So you need to take your DCB very quickly and your ideal aim is to keep it inflated for at least 1 minute. So now we'll do the final case. So we're taking, so once this we finished with our DCB, we've gone to 14 atmosphere, right? Yeah. So we are in a 14 atmospheric situation. So so it's almost a minute now. Let's see how things go.
Is it DCB, Appa?
This is a drug-coated balloon. Yes, this is a drug-coated balloon.
Will you do it in the kissing fashion with LM?
Yes, we will do a kissing. After this, we'll take 2 balloons, separate, properly sized, and then we'll do a kissing. And then this we are waiting because we have to keep it inflated for 1 minute. So our 1 minute time is up and we are taking out our DCB now.
Any questions from the audience? Already, yeah.
Appa, are you going to do the
Yeah.
DCB in the diagonal as well?
No, we will not. We are happy with whatever flow the diagonal is. It's not that great a vessel. I mean, the thing is, the fact is that we've treated his left main, we've treated his LAD lesion. So I think we've done a fairly decent job. We will not be chasing small or medium-sized vessels right now.
Madam, one question is from our Dr. Nurul. Noor Alam. Dr. Noor Alam, one question raises that should you go for the functional or physiological assessments of the side branch?
If you
L6,
want to,
yeah.
you can, but here there was significant with IVUS, we saw that there was significant calcium there It's a moderately sized vessel. Here, I think FFR is not warranted, but of course, if you want to do that, you can do it. But here we will not be doing FFR.
Okay.
Can
So
you
we are
give us a
taking
check
a
and after the DCB, we have
2.5 by 8
Uh,
for our left main to LCX, and we'll be taking a 3.5 by 8 for the LED, and then we'll do kissing.
we have not- Can we have a check angio after the DCB? We've not seen how the vessel looks now.
Excuse me,
Can you give us a check shoot after the DCB?
oh yes, so
Dr. Asha,
let us do the kiss and then we'll show you the,
Asha,
everything looks fine,
practice.
so. I mean, there's always this question also of how much dye do you want to use? We are a great believer in using the minimum amount of dye. So we use different tools like IVERS, and you can show them the strand widths that we used. So the strand width showed that can we, okay, so we did a stand widths in the meantime. So that also showed that the stand in the LED was quite nicely open. And now once we do our KBI and the report, we'll take a shot and we'll also do the IVERS. Otherwise, the patient is doing fine.
Dr. Asha, I want to know from you, what is your usual strategy when the side branch should be approached with DCB and requiring kissing balloon inflation with the main branch? Do you usually do kissing with that drag balloon, or after placing implanting drag balloon, then you will take another balloon and do the kiss?
Actually, what we do is with the same DCB balloon, we do
That's
it.
it, that's it. As you know, that after the placement
DCB,
of
nothing
DCB,
else
you
should
should
go.
not impair the vessel.
Nothing else should go.
Thank you.
So here we also tend to use a DCB, the DCB balloon, but here we felt that the DCB balloon was a bit undersized. It was only 2 millimeters in size. So so we thought that for we slipped a bit. So yeah, so we'll do a
What are the sizes of, madam, size of your balloons in the LED?
3.5 for the 3.5 for LED and 2.5 for the.
How you dilated it sequentially or?
Madam, actually, we are running short of time. I think I may request our chairperson for a few comments. Later on, you will conclude the session, ma'am.
So let us take a final picture,
Yeah, ma'am.
and we will be doing the IVERS as well. Let's see.
Almost finished. Work is almost finished. Now, final pot and then finish, IVAS, then finish.
Yeah, so they need to see the picture angiographic as they're leaving. So we're doing a bit of post dilatation. So they want to see a picture. Yeah, so let us show the picture first, and then we can always do the report and the check, please.
For the younger colleagues, as she has done KBI, after KBI, report is mandatory.
So this is our angiographic final result. And you
Excellent.
can see now we'll do report, and then we will do an IVERS imaging.
Thank you, madam. It looks excellent. I think so.
Yeah, so we will be taking a larger size balloon now for the report of the left main.
Thank you, madam.
This is a 4.5, and we'll do a final IVERS.
Thank you, madam, for your brilliant case. Now I giving my mic or handing over mic to Professor Subia Rahman for final comment and
Conclude the
concluding
session.
the session.
Yes.
Well, all of us have seen, and you've done a very wonderful job and perfectly done. And the points were highlighted time to time by the panelists here. I think all of us, those who want to make yourself, there is a gap in your knowledge, you could have improved it by seeing this. So it's a wonderful job. Nice to see you working like this.
Thank you, madam. Thank you.
Keep going, and that's
Thank
the
you.
main. And whenever you do main stem, all of you, please remember that, do it slowly, surely, and then you will be able to make sure that you have done the job. And then if you are in confusion, always discuss with your team. That is another thing. Don't think that you know everything. So wonderful job. Thank you. Congratulations to your team.
Thank you, madam. Thank you. We're very grateful that you were
Time.
present in this case. Thank you. So now we're taking the IVAs and it'll take us a minute or so, but
I was with
thank
you.
you. No,
Because-
now we're taking the IVAs now. So if you can stay with us for a minute, we can show you the IVAs. But if you,
Was not there when we started here.
Off করে দাও,
so the IVAs catheter, so we'll just show you the bifurcation maybe. Can we go live? So there was a lot of
Now we are
calcium,
seeing
right?
the IVAs.
So the stent struts are nicely opposed, and as we can see, LCX is coming at 5 o'clock position, right? So now we're in left mid. I think I jumped a bit, but so it's very nicely opposed and it's covering the ostium, as you can see. So the stent is covering the ostium, and you need to keep 1 or 2 struts outside the, so that you don't miss the left main. So that was the IVAs, and the LCX looks fine as well. So
What was your initial dia of the left main, madam? Vessel dia?
that was 4 millimeter,
4 millimeter. And we have post dilated with 4 millimeter.
4.5, 4.5.
Enough, enough.
So thank you. So that's us done, and we're very happy that we could be part of this very prestigious conference. Thank you from the entire team of National Heart Foundation.
On behalf
We're
of
extremely
Bangladesh Society of Cardiovascular Intervention, we must congratulate you for your brilliant case. Thank you, madam.
Thank you.